Good morning. Welcome to Neuroscience Ground Rounds. This is our first one of 2024, so we're very excited about this. Before we start, I do have a statement that we need to make on behalf of the CME team, and that is that there's no commercial support for today's activity. The speaker and planners have disclosed no relevant financial relationships with any commercial interests. After today's activity, you will receive a SurveyMonkey link. Either if you're here in the auditorium, we'll have handouts at the back. If you're online and in the auditorium, we'll have a QR code on the last slide. And then also, if you are online, we will provide in the chat box towards the end, we will provide the SurveyMonkey, the actual link that you can click on to claim your CME credit. And it says if you have a question, please enter the Q&A chat and we will ask at the end of the presentation. So we'll save all your comments or questions for the end of the presentation. So without further ado, I'd like to welcome Dr. Chen. She is one of our wonderful inpatient neurology physicians, and we are so thankful that you came this morning to present on cryptococcal meningitis. And this is going to be a very exciting case to hear. So thank you so much.
All right. Thank you, Lauren. Like she said, my name is Lucia Chen. I'm here to talk about an interesting case of meningitis that saw several years ago. The patient had some interesting complications. Before we get started, like she said, I have no relevant disclosures. So the case starts with a 26-year-old male. He initially presented to another hospital with headache, blurred vision, hearing impairment, neck and back pain, and weakness and numbness in the legs. Notably, he was a poor historian. We later found out that he had been involved in an altercation, actually had been locked in a shed outdoors overnight prior to presentation. Before this event, he was previously healthy. He didn't have any relevant past surgical history, didn't have any known drug allergies. He had a history of IV drug use and tobacco use, but he had been recently incarcerated and hadn't used anything since that time, about 6 months prior. He also had no pertinent family history. On exam, he had subjective neck stiffness, but was able to flex his chin to his chest. He was drowsy, but able to participate with the exam, had very poor visual acuity, but able to see hand wave, and had generalized weakness without any focal findings. On initial imaging, he had diffusion restriction in the left basal ganglia with flared correlate. He also had diffuse leptomeningeal enhancement with a little bit of enhancement in the area of diffusion restriction. The patient had a lumbar puncture at the outside hospital with an elevated opening pressure of 50 centimeters of water. He had a lymphocytic pleocytosis, elevated CSF protein, low CSF glucose, negative gram stain, positive CSF cryptococcal antigen, and his CSF fungal culture eventually returned positive for Cryptococcus. Serum cryptococcal antigen was also elevated, and HIV serology was negative. He was appropriately started on antifungal therapy with amphotericin and flucytosine on hospital day 2 at the initial facility. However, he continued to have waxing waning mental status and was transferred to our facility on day 6 due to persistently elevated ICPs. After transfer, he remained drowsy but able to participate, continued to have very poor visual acuity, and was noted to be unable to hear. The way that the examiners interacted with him was by writing very large on a dry erase board and holding it right up to his face. Other than that, he continued to be generally weak, but without any focal findings. He had a repeat lumbar puncture. The CSF jetted out of the needle, so it was estimated to be greater than 50 centimeters of water opening pressure. Continued to have a lymphocytic pleocytosis with elevated protein. Glucose this time was normal. Still had a negative gram stain. The cryptococcal antigen, again, came back positive. And again, his CSF fungal culture grew Cryptococcus. And the repeat of the serum cryptococcal antigen and HIV tests were unchanged. Patient had a lumbar drain placed on hospital day 3 in his total clinical course. This led to improvement of his mental status, but he continued to have some fluctuations. Fungal culture from the lumbar drain samples were negative, although the cryptococcal antigen in the fluid continued to be positive. He had an immunodeficiency workup, which was unrevealing. And because he was unable to take PO due to persistent nausea and vomiting, he was switched from amphotericin and flucytosine to amphotericin and fluconazole. The lumbar drain was removed on hospital day 12. So our service was involved on hospital day 14 due to episodic decreased responsiveness with ocular bobbing and head and body turning to the right. Patient was also noted to be more agitated and confused at this time. On our exam, he was not really able to participate as much as he had previously. He was unresponsive to sternal rub, didn't have any obvious gaze deviation on passive eye opening, and withdrew from pain in all four extremities. 2-hour EEG just showed generalized slowing without any seizures or epileptogenicity. He had another lumbar puncture that again had an elevated opening pressure, pleocytosis with lymphocytic predominance. But interesting, this time his CSF fungal culture came back negative. They didn't send the cryptococcal antigen from this tap. On repeat MRI, there were some new findings. So you can see the prior MRI on the left and the new MRI on the right. He had extension of diffusion restriction in the left basal ganglia, as well as involvement in the right basal ganglia and periventricular white matter. There's also thought to be diffusion restriction in the parasagittal frontal lobes. However, this may have been an artifact. And there's also diffusion restriction in the left side of the splenium of the corpus callosum, which was not present previously. On FLAIR, there were correlating changes to the diffusion restriction. And on the T1 post-contrast, the patient had more prominent leptomeningeal enhancement, especially in the frontal lobes, as well as continued enhancement in the basal ganglia. Further down near the skull base, the enhancement was a lot more prominent, and he had some nodular enhancement in the area of Meckel's cave. Differential at this point included several things, including inadequately treated cryptococcal meningitis due to the switch to a different antifungal agent, cryptococcal meningitis which was refractory to typical treatment, new cerebritis or abscess formation, inflammatory changes, or venous sinus thrombosis, considering the left splenium lesion. Further clinical events included EVD placement with improvement of mental status. Eventually, this was converted to a VP shunt. Patient was switched back to flucytosine and tolerated this well. And then later on in the course, we were re-engaged due to increased agitation, confusion. Exam at that point was largely unchanged. Shunt series was negative for abnormalities in the VP shunt. The shunt tap disclosed, again, pleocytosis, again with lymphocytic predominance, markedly elevated CSF protein, and negative cultures. The patient had yet another MRI, this time kind of still showing the same areas of diffusion restriction, as well as involvement of the splenium of the corpus callosum as before. However, on FLAIR, he had marked edema in the subcortical white matter, and this was more prominent in the superior sections. Also, he had increased leptomeningeal enhancement, and the enhancement at the skull base was unchanged. So to continue his clinical course, since his CSF fungal culture remained negative, persistent infection was felt to be unlikely. This is felt to be an inflammatory process, and the patient was started empirically on prednisone for post-infectious inflammatory response syndrome, or PIRS, with dramatic improvement in mental status and hearing. His CSF SCD25 returned elevated, and we'll talk a little bit more about what that means later, but this confirmed the diagnosis. So I just wanted to talk about cryptococcal meningitis and some immune complications which can occur as a result. As you all know, Cryptococcus is a fungal organism. Most human infections are caused by two species, Neoformans and Gaddii. Incidence is about 1 million cases per year. Estimate of mortality varies between 100,000 and 500,000 deaths per year. Most cases occur in sub-Saharan Africa, and most patients are positive for HIV. It's an AIDS-defining illness in patients with a CD4 count less than 100 who are not on effective antiretroviral therapy. However, it can affect some patients who do not have HIV, most of whom are immunosuppressed for other reasons. For example, patients who have had a transplant and are on rejection medications, patients with congenital immunodeficiency syndromes. However, in some patients who are immunocompetent, we also see cases of Cryptococcus. The fungus is thought to invade the body via the lungs. It causes a pulmonary infection. In most patients, or in most healthy individuals rather, it's subclinical. However, the infection in clinically significant cases can have a latent period where the organism is dormant in the pulmonary lymph nodes before becoming disseminated. Cryptococcus has a high neurotropism due to several virulence factors, including the ability to penetrate the blood-brain barrier, neuroimmunomodulatory enzymes, and adaptation to survive low-nutrient environments such as the CNS. And for this reason, meningitis is the most common presentation of cryptococcal infection. So patients present with typical signs and symptoms of meningitis, including headache and confusion, fever and malaise, signs of increased ICP such as nausea and vomiting, diplopia, and decreased visual acuity. And without treatment, this can progress to seizure, coma, and eventually death. Time to presentation varies based on population. In HIV-positive patients, they tend to present more quickly within the first 2 weeks, whereas it can take HIV-negative patients longer to present for medical attention, up to 6 to 12 weeks. Typical MRI findings include leptomeningeal and pachymeningeal enhancement, similar to other forms of meningitis. Patients can also have dilated perivascular spaces, hydrocephalus, cortical lacunar infarct, and cryptococcomas, such as seen on this figure. Workup includes a spinal tap, which usually discloses increased ICP, lymphocytic pleocytosis, elevated protein, and low CSF glucose. Classically, Cryptococcus was identified via India ink stain. However, we can also send an antigen detection test as well as fungal cultures. Treatment for cryptococcal meningitis includes an induction phase with intense antifungal therapy, typically amphotericin and flucytosine or fluconazole. This is followed by a consolidation phase with high-dose fluconazole, and then after that, followed by lower-dose fluconazole for maintenance therapy. In HIV-positive patients, this can be discontinued once their CD4 count recovers to greater than 100. So increased ICP is a common complication of cryptococcal meningitis. It's more common in HIV-negative patients than HIV-positive patients. And management includes serial therapeutic LPs or lumbar drain, and BP shunts are rarely needed. And again, this is more common in HIV-negative patients. As I said earlier, there is a significant mortality to cryptococcal meningitis. In HIV-positive patients in the developing world, it's as high as 60 to 70% of cases. In the developed world, it's lower at 15 to 24%. And notably in non-HIV-related patients, the mortality is about 27%. So like I said, there are some interesting immune responses to cryptococcal meningitis. In healthy individuals, inhaled cryptococcal organisms are detected by alveolar macrophages, which break down the organisms and present the antigens to dendritic cells, which in turn activate the T cells. The T cells in turn recruit macrophages, which encapsulate and eventually eliminate the organism. In patients who have clinically significant cryptococcal disease, some stage of this immune cascade is deficient. However, in immunocompetent individuals, they can actually have an overactive immune response leading to inflammatory damage. One of the common immune complications from cryptococcal meningitis is IRIS, immune reconstitution inflammatory syndrome. As you all know, HIV depletes your T cell population, and so they're unable to mount an appropriate response at the T cell stage of the immune response. Other organisms which can be associated with IRIS include tuberculosis, Mycobacterium avium complex, certain viral infections, and other fungal infections. The diagram on the right illustrates what happens with IRIS. The top of the sample, or the top example, shows a healthy response, kind of like we discussed in the previous slide. In the lower example, on the left, you can see a patient who has not been treated for HIV and has a low T cell population and is unable to mount an appropriate response, leading to overpopulation of the fungal organism. Ideally, after starting antiretroviral therapy, patients are able to recover their T cell count and mount an appropriate response. However, in some patients, there's an overactive activation of T cells leading to inflammatory damage downstream. There's several ways that IRIS can present. One is with paradoxical iris. This is in HIV-positive patients who respond to antiviral therapy and are later started on ART. This occurs in 10 to 20% of patients with a median onset of 60 days after starting ART. Risk factors for this include a low pre-ART CD4 count, a low initial CSF white count, low markers of inflammation, and high or initial or persistent fungal burden. There can also be unmasking iris, so patients who are started on ART and present with clinical cryptococcal meningitis for the first time. These patients tend to have a lower fungal burden, as well as an increased inflammatory response compared to patients who have paradoxical iris. There can also be an iris-like syndrome in patients who do not have HIV, but are immunosuppressed for other reasons. For example, patients who are on chemotherapy and are switched to a different regimen. Evaluation for iris includes exclusion of persistent infection with a repeat lumbar puncture. While awaiting results of this, it's recommended to consider repeating induction therapy. And treatment for iris includes a course of steroids, the length of which varies based on severity. In severe cases, the recommendation is to start a TNF alpha blocker such as adalimumab, as well as delaying this restarting antiretroviral therapy for another 4 to 6 weeks. Another immune complication of cryptococcal meningitis is what our patient had, post-infectious inflammatory response syndrome, or PIRS. This presents with clinical deterioration in HIV-negative immunocompetent patients during or after adequate antifungal therapy. The incidence is not well measured in the literature. However, one case series estimated that it occurred in about 36% of patients with a median onset of about 50 days after starting antifungal therapy. It occurs more commonly in Cryptococcal gattii rather than Cryptococcus neoformans infections. The pathophysiology of this is not well understood. It's thought to have a couple of components, one of which is dissociation of the macrophage T cell activation, leading to inadequate fungal clearance. It's also thought that there's an aberrant activation of downstream macrophages. The usual phenotype of macrophages in cryptococcal meningitis is the M1 phenotype. This helps eliminate the fungal organism and is also helpful in other fungal infections. However, there's a second phenotype called the M2A macrophage phenotype, which is activated in these patients, but does not actually help clear the fungus. And it's thought that this leads to persistent fungal burden, leading to continued inflammation. So PIRS is associated with elevated ICP of greater than 23 centimeters of water. Patients also tend to have a greater incidence of hearing impairment. This is another example of PIRS in a different patient from a case presentation in the literature. She initially presented with cryptococcal meningitis with cryptococcomas. On day 1, her MRI showed edema around the areas of cryptococcal infection. So she was started on steroids in addition to the usual antifungal therapy. This led to a reduction of inflammation and edema on the follow-up scan 24 days later. At that point, she was taken off of steroids due to concern for immune suppression. However, she presented with worsening mental status later on, day 34. Repeat MRI showed worsening of edema and inflammation, and she was restarted on a course of steroids with a longer taper. Evaluation for PIRS includes, again, ruling out persistent infection with a lumbar puncture. Notably, cryptococcal antigen may continue to be present due to inadequate clearance, even if the culture is negative. Importantly, evaluation also includes measurement of CSF cytokines, including T cell activation markers such as soluble CD25 and CD27, which is what was measured in our patient. Treatment for this condition includes, again, steroids. The exact treatment is not well defined, but the recommendation in some of the literature includes prednisone 1 milligram per kilogram, again with a long taper. Just to sum up the key points of the presentation, we should keep in mind that the immune response to cryptococcal meningitis can be as clinically damaging or more clinically significant than the infection itself. Management of cryptococcal meningitis includes treating both the fungal infection as well as managing the inflammatory downstream effects. We should also keep in mind that, or keep an eye out for PIRS in cases of cryptococcal meningitis in immunocompetent patients who received antifungal treatment and have a negative CSF culture, but continue to have clinical deterioration. That's it. That concludes my presentation.
The post-infectious inflammatory response syndrome, can it be even seen in bacterial meningitis or any other infectious meningitis?
I believe it was mostly, like I said earlier, I didn't say. I believe it was mostly like HIV or AIDS-defining illnesses that I read about. So.
The routine, like other bacterial meningitis.
I'm not sure. I imagine you can have a similar pathophysiology. So I suppose it's possible, but I don't know.
Right.
Yeah.
You didn't come across with any case reports.
Yeah.
Okay.
By chance, first of all, great presentation. I actually learned a lot. There's a lot of that stuff. I was like, wow, okay. So in regards to Cryptococcal meningitis, do you know, like talking with peers, what the incidence in our health system is like?
Yeah, well, I haven't actually looked into the incidence in Georgia, but I know that Laura and I were speaking the other day, and there's a high incidence because of like the chicken plant workers. They have exposure to, chicken waste.
Yes.
So I imagine, they get exposed a lot.
It'd be interesting, because we talk about, avian species and their fecal waste being a common carrier or a source for Cryptococcus. And this is the poultry capital of the world. Or if you're Caleb Trites, who's one of our techs, it'll be Livonia, Georgia. Yeah, just in terms of have you guys seen more of this here?
Again, I've been here in my last 3 to 4 years, I have seen 2 patients with cryptococcal meningitis here. One of them was, yes.
And if there's any questions or comments from those online, if you would please put those in the Q&A box, down at the bottom of your screen, not the chat box, if you have any questions there. Okay, thank you, Dr. Chen.